Welcome to the Sound of Ideas from IdeaStream Public Media. I'm Stephanie Haney. Thank you for being with us. When you hear seasonal affective disorder, you probably think of the cold, dark days of winter. But for some people, seasonal depression arrives at the opposite time of year. As temperatures rise and sunshine stretches into the evening hours, sadness, anxiety, and irritability can become more prominent. Today, we'll discover how heat, light, and seasonal changes can affect our mental health. Joining me today, we have friend of the show, Dr. Alicia Roth, behavioral sleep medicine psychologist at Cleveland Clinic. Dr. Roth, thanks for being here.
Thanks for having me again.
We want to know if you experience summer blues. Does the heat affect your mood or your sleep? We would love to hear from you. You can join this conversation by giving us a call at 866-578-0903. You can send us an email at soi@ideastream.org, or you can message us on Instagram at The Sound of Ideas. And perhaps maybe there's someone in your life who you think might be dealing with seasonal affective disorder in the summer, and you want to know how you can be a better support or just understand it more fully. We would love to hear from you. So we'll start, Dr. Roth, by asking you to set the stage for us. How would you describe seasonal affective disorder?
Well, seasonal affective disorder is it's a type of depression that has a seasonal rhythm or component to it. It has a seasonal pattern. And the most common type of seasonal affective disorder happens in the fall and the winter time. So most people who are affected by this seasonal pattern of depression usually find it happening in the winter. But, a small percentage, very small percentage of people have a seasonal pattern to their depression that happens in the summertime or the springtime as well. And it's a little bit different. In the winter, we think of seasonal depression as being kind of sad mood, low energy, maybe lots of sleep, or eating a lot more. But in summer seasonal depression can look like agitation, less eating, insomnia, anxiety. So they have a bit of a different presentation.
Okay. And when we talk about what triggers seasonal affective disorder in the winter versus the summer, can you tell us some of the things in the summer that might make people susceptible to experiencing this?
Honestly, it makes more intuitive sense about the winter. The winter seasonal affective is that the days become shorter and we get less light. And for people like me who study sleep, it's a pretty clear connection between our melatonin production and our circadian rhythm system gets disrupted in the winter. Because melatonin production has a lot to do with our access to natural sunlight, not just screens or indoor light, but natural sunlight. And so when we get less natural sunlight, our melatonin production it doesn't get suppressed the way it does in other times of the year. And so when that melatonin doesn't get suppressed, we feel drowsier, we feel kind of lethargic, that might turn into depression. The summer is different though, right? Because we have plenty of sunlight. And one explanation of what could be happening with our melatonin and our circadian rhythms in the summer is it's just a change. It's a big change. We have longer days. We have this kind of man-made construct of the time change where we shift the time to be later in the day. And so, any change in our rhythms, in our circadian rhythms, those internal clocks, but I think for summer seasonal affective disorder, there's a lot of external factors that are affecting our mood. So disrupted routines, if you've got the summer, whether you're a child or you have a child that's out of school, your summer gets disrupted. There's a lot of social pressure in the summer, and a lot of social media pressure and FOMO, fear of missing out. There's that pressure to be out and about, and so for some people, not matching that expectation can be really difficult too.
What about the heat? The heat in the summer, is that a factor?
Sure, the heat can lead to that agitation and anxiety. Especially, as we're having hotter summers, and if you don't have access to cooling or air conditioning, that can cause, depression in a different way, not so much sad mood, but agitation or anxiety.
And allergies?
And allergies.
There is scientific evidence that allergies are getting worse. They're lasting longer and
Sure.
being more intense. Is
Yeah.
that a contributing factor?
There's some biological evidence that the seasonal allergies can lead to inflammation, and that can cause lead to more risk for depression. But also, it's just aggravating to have seasonal allergies too, and so that can also lead to a change in mood.
If you're just joining us here on The Sound of Ideas, we are talking about seasonal affective disorder that presents in the summer SAD. If you want to be a part of this conversation, the number to call is 866-578-0903. You can also send us an email at soi@ideastream.org, or you can send us a message on Instagram at The Sound of Ideas. We have an email now in from Marvin. Marvin writes, I never knew there was a summer version. Do people typically get one or the other, or is it common to suffer in both winter and summer? Can people get both seasonal affective disorder in the summer and the winter, Dr. Roth?
That's a really good question, and there's much less research on summer seasonal affective disorder because disproportionately people who suffer from this suffer from it in the winter. But this is not its own diagnosis. It's a subset, a type of depression, and one of the symptoms and one of the patterns is that you do have relief from the depression in the opposite months, right? So it doesn't sound intuitive that summer you'd have the summer depression and then in the winter you'd be okay, but there's a seasonal pattern to it and there's seasonal relief as well. So it wouldn't be year round. If it had a seasonal pattern, you'd also see periods of relief as well.
I see. That makes a lot of sense. We talked a bit just a moment ago about time change and how that can mess with your melatonin production. This is a controversial question, but if we got rid of the time change, do you think we might see a decrease in seasonal affective disorder?
I think it would be less jarring, right? The thing about the time change is that it's so jarring to us, especially the spring forward in March. People have the hardest time with that because people ask, how do I adapt to the time change? What do I do for the time change? It's very difficult. It's a loss of 1 hour of sleep. So you can't really work around that. It's a loss of 1 hour of sleep to get that time change. And it's very jarring to our brains and our bodies for the sun to come out later and be out longer. And so like I said, any time that there's a disruption in that pattern, we're at risk for changes to our behavior and our mood based on that outside pattern.
I would just like to speak on behalf of everyone and say a delayed start might be nice when we lose that hour of sleep.
Right. Scientific communities have said that is if you're going to, shift our timing, then why don't we shift the timing of work just a smidge? Or, we still have to wake up at the same time and behave at the same time. So why don't we shift that as well?
Let's talk a little bit more about how SAD presents in the summer and how it might be different than how SAD presents in the winter. You mentioned agitation. I have read that agitated aspect of this makes it more active and can lead to greater incidence of perhaps self-harm. Is that something that you see?
Yes, and it's similar to people who have a condition we call bipolar disorder. Not that summer SAD is bipolar disorder. There's a distinction, but people with bipolar disorder have what we call manic episodes and those high highs and the low lows of depression. And so the high highs include agitation, irritability. They could make risky decisions, do risky things, make big decisions in a short amount of time, have a lot of anxiety. People who are manic, they don't sleep, but they don't really miss sleep because they're going. And there is some evidence for people who have bipolar disorder for the summer to be a time where you're more at risk for a manic episode, but it looks a lot like that.
Is there an impulsiveness that's associated with summer sad? That seems to be something that kept popping up when I was looking at things preparing for this segment today.
Yeah, it could be if you're trying to meet. It depends on where you're, what external factors you're dealing with, but specifically thinking about that social pressure and that fear of missing out and looking at, everyone having a great time on social media, you could make impulsive decisions about, going to a vacation or going, visiting a certain spot or doing a certain thing that you see on the internet, just based on that fear of missing out.
And that could include people who are harming themselves. We do see greater incidents of death by suicide in the summer as well. If you're just joining us here on The Sound of Ideas, we are talking about seasonal affective disorder as it presents in the summer sad. You can give us a call if you'd like to share something about this, or if you have a question for our expert here, Dr. Alicia Roth. The number is 866-578-0903. You can also email us at soi@ideastream.org or send us a message on Instagram at The Sound of Ideas. Now, we talked about this a bit before when we had the question from Marvin about whether people can experience both winter sad and summer sad. You mentioned seasonal relief. How do you distinguish, maybe that's the best way to distinguish, but maybe there are other ways to distinguish between temporary summertime sadness from a more serious issue, from a more generalized depression?
Yeah, so I think the seasonal relief is the biggest thing. Is when we're talking to a person who's coming in and talking to us about feeling depressed. Is we ask, does it come and go? Is it all the time? If it comes and goes, does it have a seasonal component, or does it come and go for different reasons? So really, the biggest distinction between sad and a more recurrent depression is the seasonal aspect of it.
And in either case, when do you know that it's time to seek help if you're experiencing these characteristics that are associated with generalized depression or summer sad?
When you start to feel like these feelings are interfering with your ability to live life the way you want to. So interfering with the basics, taking care of yourself, going to work, going to school, taking care of your family, taking care of your kids, but also interfering with things that you normally like to do for fun. So your hobbies, your interests, I like to say in Northwest Ohio or Northeast Ohio in the summer, the mood is different in the city here. I'm from Florida originally, and so we don't see seasonal affective disorder as much. And when I moved here 8 years ago, I was like, wow, okay, I get it now. I get it. There's different seasons, and your mood might be different. But it's when you start to see that it's really affecting your ability to live the life the way you want is to ask for help.
Okay. Going back to the conversation we were having about time change, we've got a question in from Stephen now, and Stephen wants to know, how long does it usually take people to readjust to the time shift?
That's really hard to say. A lot of people ask that question. It might take a couple of weeks, but it also depends on your own circadian preference. If you're a morning person, it might be, the time shift might be difficult for you when we shift forward because the light, we're shifting the light later. We're not getting more light. We're just shifting it later. And so it might be more difficult for a morning person when that light gets shifted later because if the light is out later, it means our melatonin is suppressed until later. And if our melatonin can't rise, then we can't go to sleep. So I think it depends on what your internal, what we call chronotype is like, how difficult it is to make that shift.
We've got a question now from David B. in Cleveland Heights. David says, I'm wondering if there's research or even anecdotally of people who either move to a different location or climate for part of the year in order to avoid the dark of winter or the light and heat of summer. What are your thoughts on that? I know you mentioned you had a different experience coming here from Florida.
Different. I used to not understand snowbirds when I was growing up in Florida. I didn't understand why why the most expensive time for the condos were in the winter. But certainly, yeah, people do this all the time from the north and the Midwest as they go down to Florida or Arizona or a more tropical or sunny or warmer climate during the winter. And it sounds very intuitive, but there's a scientific basis for that. In terms of keeping up your mood. I mean, the other thing about keeping up your mood is not just the melatonin, but it's the access to activities. One thing that happens, here in the Cleveland, the Northeast Ohio area is, we're just so we're so buttoned in. We can't do as much as we used to. We're not going out as much. We're not socializing as much. We're not doing as much physical activity. And I know when I have patients who snowbird in the winter, and they're calling me from the beach, and they're taking a walk every morning on the beach, it does help with their sleep and their mood quite a bit.
Okay. We had a call from Rich in Lorraine. Rich couldn't stay on the line, but Rich has summer sad. And Rich says one of Rich's triggers is noise pollution, things like lawnmowers, loud music, motorcycles. That makes Rich's depression worse. Is that common?
That's a really good point, is that, the summer, especially here, is a lot noisier because, like I said, people are out and about, and people are, if you live close to the city, I live close to the city, and yeah, you hear fireworks all the time and motorcycles and people just out in their yards, and so that could definitely contribute to some sleep disturbance.
Okay. Another email now in from Tom, getting a lot of great questions here. If you do have a question about seasonal affective disorder in the summer, now is the time to get that question in. You can call 866-578-0903 or email us at soi@ideastream.org or send us a message on Instagram at The Sound of Ideas. Tom writes in, I wonder if a contributing factor to summer sad is the more frequent and severe summer spells of wildfire smoke, which affect breathing and circulation, and probably fatigue, and perhaps even the dread of being trapped in a polluted air environment. Tom, thank you for the thought. What do you think about that? More time outside in the summer, more immersion in what might be a polluted air environment?
Yeah, I don't know if there's any research on that, especially the link between the wildfires. But just like we were saying, there's a lot about our environment that can biologically trigger inflammation, with those seasonal allergies. I'm sure that, wildfire smoke can contribute to that as well. But also, if you think about if we're getting wildfire smoke here, we're asked to stay indoors, right? So we're changing up our routines. And again, anytime you change your routine dramatically, whether it's a physical activity routine or a mental activity routine, you're susceptible to, having some issues with your mood or your sleep.
Is it possible to get ahead of SAD in the summer and maybe do things that might help ease the way your symptoms show up?
Yeah, it's very similar to, what we recommend to people who have winter SAD. Sticking to a routine in the summer, particularly staying cool, and setting limits and expectations for what you might do. Again, those expectations for being out, more out every night, and reducing that fear of missing out. For patients who get diagnosed with this, you have to demonstrate it over maybe a couple of years' time to get a diagnosis of this, because it has to. It's not just I show up and I'm depressed in the summer. That's not seasonal affective disorder. You have to show a pattern of it happening over a couple of years. And so if you're working with a psychiatrist or a mental health professional or your family doctor, they might say, let's get ahead of this by prescribing an antidepressant or a medication that's going to be helpful in keeping your mood at baseline and level.
So that is something that is a potential treatment option for SAD, is antidepressants. This is something we'll be talking about at length in the second half of the show here. Let me ask you this. What about light therapy? I know light therapy is useful for seasonal affective disorder in the winter. It is a different kind of light. It's full spectrum light. Can that be helpful for summer sad?
Yeah, it's there's such a lack of research in this area. There aren't clinical trials that show that doing this is going to help. And really, you think the problem is sunlight. So why are we giving more sunlight? But if you think about it as sunlight and that full spectrum, like light, when you say light therapy, I'm thinking of like a light box and, actually sitting next to that light box. What it does is it entrains your rhythm and entrains like that chronotype of waking up at a certain time and falling asleep at a certain time. So light therapy, within an hour, first thing in the morning, is not a bad thing for anyone, especially if you have seasonal affective disorder. But in the summer here, there's just more opportunity to do it without a light box. You could actually go outside in that first hour and get that sunlight exposure.
Sure. But maybe you do it inside with the light box. Maybe you don't have to deal with the allergies.
You don't have to deal with the
heat.
allergies or the heat.
Yeah.
You're getting like a big dose of it. You don't have to worry about a cloudy day or a rainy day. But no, you make a good point. It's like you eliminate all of the difficult parts about being outside.
Sure. Well, this has been a fascinating conversation. Dr. Alicia Rothman, and thank you very much for the time.
Thank
Behavioral
you.
sleep medicine psychologist at Cleveland Clinic, who has been here several times now, officially friend of the show.
Friend of the show.
We appreciate it very much.
Thank you so much for having me.
We're going to take a quick break now, and when we come back, we are clearing up misconceptions and confusion about antidepressants. This is The Sound of Ideas. I'm Stephanie Haney. Stay with us. You're with The Sound of Ideas from IdeaStream Public Media. I'm Stephanie Haney. Thank you for staying with us. As we've been talking about already today, many Americans struggle with depression. A recent Gallup poll found that 18% of adults reported having depression last year. Antidepressant medications have been shown to help ease depressive symptoms. One common type of these medications is called selective serotonin reuptake inhibitors, or SSRIs. You may have heard of SSRI brand names like Prozac or Zoloft. These kinds of antidepressants were used by more than 11% of adults in 2023. That's according to the Centers for Disease Control. More adults in the Midwest specifically take antidepressants than in any other region in the country. U.S. Health Secretary Robert Kennedy Jr. has been openly skeptical about the use of SSRIs and last month announced a plan to address what he's calling the, quote, overuse of psychiatric medications, especially among children. This is in favor of what he calls a more holistic approach to mental health. But psychiatrists have warned that some of the claims about the side effects of antidepressants are misinformed, including that their use is associated with an increased link to mass violence. And there's concern that Kennedy's framing may result in limiting access to treatment for millions who rely on it. To try to clear up confusion and misconceptions around antidepressants, we're joined now by mental health experts to talk about how these medications work, who needs them, and how our perceptions of these drugs have changed over time. Joining me in studio, we have Dr. Corrine Koifman, Professor of Psychological Sciences at Kent State University and the Director of Brain Health Research Institute. Thanks for being with us.
Happy to be here.
Also with us here in studio, we have Dr. Jonathan Sadowski, Chair of the Department of History at Case Western Reserve University. Dr. Sadowski, thanks very much.
Happy to be here.
And joining us by video, we have Dr. Felipe Amunanatigi, Child Adolescent Psychologist of University Hospitals. Thanks for being with us, Felipe.
Thank you for inviting me. Thank you very much.
If you want to be a part of this conversation, you can give us a call at 866-578-0903. You can also email us at soi@ideastream.org, or you can message us on Instagram at The Sound of Ideas. And we'll start this conversation, Jonathan, asking about the history of antidepressants. Can you tell us what's the earliest record of an antidepressant?
Well, it depends what you call an antidepressant. People have been using various substances to try to treat perceived disorders of mood since antiquity. And Arguably, the first real antidepressants were when the amphetamines were developed in the early 20th century. They weren't called antidepressants then. We didn't have that word then, but they were used to treat low mood, particularly mild low mood. They weren't generally used to treat severe, what we would now call severe depression. In the middle of the 20th century, there began to be an uptick in interest in depression, an increased use of the word, increased diagnosis began then, and then, the first antidepressants were not developed in an attempt to develop antidepressants. They were accidental discoveries that came from other drugs. There's a class of drugs called the MAOIs, and these were really the first antidepressants, and they were originally developed to try to treat, they were actually intended to be a tuberculosis drug, and they were perceived to have effect on mood, so people tried them for depression. Then there was another class of drugs called the tricyclics, and these were developed actually out of schizophrenia research, and the person who originally was doing this research found that the tricyclics improved mood in schizophrenic patients, but did not cure psychotic symptoms. But he thought if they improved mood, well, maybe it'll work for depressive symptoms and depressive disorders. So he tried that. Both the MAOIs and the tricyclics had some adverse effects. Most drugs do. In fact, I think virtually every drug has adverse effects. It's a matter of cost-benefit analysis whenever you take a drug. But there was a search for alternatives to these because they were shown to be effective, but they did have adverse effects. And this was one of the reasons that the SSRIs were developed. And the SSRIs, unlike the MAOIs and the tricyclics, were developed intentionally based on a hypothesis, the serotonin hypothesis. I have to insert here now that serotonin was discovered in the city at the Cleveland Clinic in the 1950s, one of our town's claims to fame. But serotonin is only one of a number of neurotransmitters that have been implicated in depressive disorders, and SSRIs only work on serotonin. I hope that's at least the beginning to your question. Oh, I just wanted to add that, but it was because there was increased attention to depression at this time. That's why they were called antidepressants, and that's why we have the term antidepressants starting in the 1950s.
Thank you very much for this, Jonathan. We appreciate that. And that MAOI, that stands for monoamine oxidase inhibitors, for anyone who may be curious. And Corinne, tell us a bit more about selective serotonin reuptake inhibitors and how those work.
Yeah, so SSRIs, which have been around for quite a while, actually I think the first published study was in 1974, are drugs that essentially serve to make more serotonin available in the synapse or the space between neurons in the brain. Serotonin is an important neurotransmitter, as is neuroepinephrine, and there is a kind of adjacent class of drugs called SNRIs, which act on serotonin and neuroepinephrine in the brain, both of which are used very, very commonly to treat depression, of course, but actually the vast majority of psychiatric conditions can be treated by these drugs. We use them for anxiety disorders, substance use disorders, eating disorders, stress disorders. They're really used across the spectrum because of their long safety record, but also their relatively the ease with which people can take them. There's low side effect profiles for them. They're pretty acceptable. And again, lots and lots of safety.
Now, Felipe, your practice area concentrates on children and adolescents. Do SSRIs work differently in children than in adults?
So they have very similar benefits. The main difference, perhaps, is that children tend to metabolize them, so consume them, get rid of them in their body at faster rates than your average adults. So sometimes you see doses that are higher or a dosing schedule that involves twice a day dosing. So that's the main difference.
I see. And Felipe, a recent study showed that 4 in 10 high school students reported prolonged feelings of sadness and hopelessness in 2023. What are you hearing about kids and their mental health? How are you feeling about that right now? Does it seem to be something that's increasing, something that's staying level?
So from the point of view of my own clinic, but also looking at national trends, there's an increasing demand and need for mental health services for children. And there are lots and lots of kids reporting significant distress at a clinical level at a younger age, middle school and younger even. So there seems to be an increase in the need and increase in the number of children that are afflicted by these conditions.
Karine, I want to go back to you. You were talking about SSRIs and the relatively low side effects that might be associated with them. Kennedy, the health secretary for the U.S., has made a lot of claims about the side effects of SSRIs, saying they're linked to violence and mass shootings, or that withdrawal from these can be worse than heroin. Can you tell us what the science is showing related to those things?
Well, I mean, I think SSRIs are a really important tool in the toolkit to treat very serious mental health conditions. And so I think it's important to remember with any drug, you wouldn't just take it away from a patient who has a condition. And we shouldn't be thinking differently about depression or anxiety than we are about other disorders or diseases. I think we know that these medications certainly can have side effects, particularly in the loading period, so the starting period at which they're in an individual's prescribed the medication, and also in the withdrawal period. And so it's really important that patients who are being treated with, with the supervision of a professional, right? And so one of the challenges we have in our mental health care field today is that actually there's limited access to mental health professionals or to physicians who can prescribe these medications, as well as the other treatments that we do have available. So SSRIs are one tool in a very large toolkit that involves all kinds of other interventions. And so it's important that people who need care have access to professionals who can carefully consider what would be the best option for that individual, of which SSRIs are a perfectly reasonable option.
Felipe, I want to ask you about something that I've seen mental health professionals say in response to some of the things that Kennedy is claiming. I've seen mental health professionals say that this focus on overprescribing is an oversimplification of the issues that we're having with the mental health crisis here in the United States. Do you think that there is a inappropriate focus on overprescribing? What do you think is happening there?
So there's a lot of misunderstanding in the public, and unfortunately in some of our political leaders, about the nature and effect of these medications. When you look at the number of people who need care and the number of people who are actually getting care, particularly in children and adolescents, there's a large number of kids that are not getting treated who need it. So I really have a hard time understanding where would be any evidence supporting that we're overprescribing these medications.
Jonathan, what can you tell us, if you can tell us anything about the history of access to mental health and the rate of prescribing of antidepressants in the country?
Well, one point I wanted to make from a historical point of view about overprescribing is that a lot of people look at surging rates of diagnosis and surging rates of medicating and conclude, well, all of those people couldn't have been, what we're just expanding the definition of depression too broadly. But that's different from actually showing that the people don't need it. And very few people who've argued the case for overprescription have actually shown that these are people who don't actually need it. And one of the things that can cause an increase in diagnosis rates is just better understanding of the condition, better recognition of the condition. There's a lot more awareness of depression right now. And, it's possible that certain parts of the population are getting more medications than they needed, but it's also likely that there are others who have less access to healthcare, less access to mental health professionals, are being under-medicated. So I agree with Felipe on that point.
I want to follow up with you on something that you were saying about this moment of mental health awareness.
Yeah.
It does seem like there is a greater level of comfort with talking about mental health publicly now than there has been even just a few decades ago. So can you tell us anything about when we see this shift from mental health conversations being a taboo topic to being more widely accepted in conversation today?
Well, I think there's a lot of factors involved, but I think one of them might be just simply that we have these effective medications now. And that had us a number of effects. I mean, one thing is, it can bring people into treatment because there's something you can do. And I'm not saying there were no treatments before, and I'm not saying there was no efficacy. That's a separate topic. I can talk about that. But I think one cultural effect that the development of the antidepressants had was that it legitimated mental illnesses as illness conditions because it gave them a kind of biological, apparent biological marker or basis. I'm not myself of the opinion that you need to have such a biological basis to define something as an illness, but that is, in our current cultural climate, that is a criterion that's often used. So I think the fact that people could see this or understand this as a dysfunction of the brain or something not working right in the body helped give it a legitimate status as illness. This is not to say, by the way, that stigma is gone and we've solved all the problems on that front. It's just, but that I think has helped. The unfortunate side of that, in my view, and I'd like to hear what the other panelists think about this, is that I think that this introduction of this idea that these are biological diseases may have led to an underemphasis on the talk therapies, which are also valuable and can also be effective.
Corinne, do you have any thoughts on that, on alternative treatments, or not necessarily alternative, but also additional treatments?
Yeah, I mean, I think it's very important to remember we have a very long track record of understanding psychotropic medications like SSRIs and psychotherapies. In fact, the dominant therapies that are used today have been around for decades, have been incredibly rigorously tested, and work quite well. And I think, even increasingly we understand that some of the kind of core facets of our mental health are determined by very basic biological processes. You were talking about them in the last segment, right? And so we even have very robust evidence suggesting that there are treatments for depression that can consist of regular exercise, for example. And so what's very important is that we consider that mental health disorders are complex. An individual is complex within their environment, and these are significant illnesses that tend to recur. And so we want to give each individual the package of treatments, including psychotherapies, which are very robust and durable in terms of long-term gains, in fact, sometimes more so than medications, depending on the individual and the circumstance. We want to give the individual the best combination, and actually often combinations are best.
Felipe, what are your thoughts on that? Do you think that the ability to prescribe medications has had any impact on additional evidence-based therapies?
So there's a couple of thoughts on that. First, I want to make reference to a historical event that was very tragic around the early 2000s, that we had print media mistakenly published parts of a study, a very large study. I was part of the treatment of adolescent depression that essentially boiled down the entire findings to headlines that stated something to the effect of antidepressants cause suicidality in children. And regrettably, many kids were pulled off of those medications. And what we saw, and this is tragic, the complete suicide trend in adolescents had been declining up to that very year. And then we saw an uptick, a significant uptick on completed suicides after there was a warning indication connected to these medications. The available evidence shows that, particularly for severe conditions, combined treatments of antidepressant medications, SSRIs, plus cognitive behavior therapy lead to the best outcomes. And there's a reality that accessing good evidence-based therapy, it's very, very difficult and hard to find. So, and as a therapist, particularly in conditions of anxiety, talk therapy is far better tolerated by a child that has already started an antidepressant medication.
Okay. If you're just joining us here on The Sound of Ideas, we're talking about antidepressant medications, particularly selective serotonin reuptake inhibitors, SSRIs. So if you have a comment or a question about this, you'd like to ask our panel of experts, we have mental health professionals, we have an historian here with us. You can give us a call at 866-578-0903. You can also send us an email at soi@ideastream.org, and you can send us a message on Instagram at The Sound of Ideas. Felipe, let me stay with you for a moment and talk about the considerations for prescribing antidepressants for children. What should parents know when trying to figure out whether an antidepressant might be right for their child or adolescent?
First of all, you want to have a conversation with a prescriber that has experience and expertise in treating children. There are nuances and subtleties that are, you know, unique to the treatment of kids that may not be attended to by somebody who's not experienced in the care of young people. That's number one. Number two, that you have a provider that is open to your questions and can be available to address your concerns and point you in the direction of valid evidence in which you can, avail yourself of information that helps you make a decision. That is a very difficult decision for a parent to make. So having somebody that provides you good information is readily available to discuss your concerns, and it helps you make sense of what the risk and benefits are and how come the ratio of those are favorable in the direction of using these medications. They've been used for a long time, literally by millions of people around the world, and with well-known effects as well as risks. So in the hands of somebody who's experienced, these are safe medications that lead to effective treatments.
Karine, when we started this conversation, I mentioned that in the last year, 18% of adults had reported depression. That same Gallup poll where that number came from also showed that adults with lower income have increased depression rates over the last 8 years, up to as much as 35% in 2025. Also, younger adults under 30. Do you think there's a connection between lower income and depression? What do you think is the connection, if there is one there?
Sure. It's a great question. I think we understand all of the kind of primary or common psychiatric disorders like depression and anxiety and substance use and eating disorders as being disorders that often manifest at the intersection of the individual and a stressful context. And certainly having economic challenges is a stressful context. And so you might consider that kind of that additional burden, that those additional stressors actually can make individuals more vulnerable, for sure. But in addition to that, I think it's pretty well established that individuals who have economic challenges often have lower access to care, right? So they're less likely to be able to receive care earlier in life that might then change a trajectory that might lead to psychiatric conditions, right? So many of the disorders we're talking about, like depression, are disorders that typically manifest in the first decade or the second decade of life, right? So typically early teens, mid-teen, late adolescence, emerging adulthood, and then they often recur. Right? So a primary depressive episode can happen early, and then it can happen again and again, and they tend to be tipped off by stressors. This is pretty well-established science. And so we can understand these disorders and anxiety disorders and substance use disorders really actually being driven to some extent by these kind of stressful catalysts. And if you have greater challenges in your kind of day-to-day living because of economic or, kind of unfair circumstances in some cases, that might make you more likely to be vulnerable.
Let me ask you this. You mentioned that people who are experiencing it later in life often experienced it in the first or second decade of life. If that is identified in the first or second decade of life, and there are treatment modalities, whether that's a medication or whether that's something else put in place, does that have any impact on their ability to handle it later in life?
For sure. And in fact, there's amazing evidence to suggest you can shift the trajectory of an individual using different types of interventions. In fact, there's a really powerful study that was published, I would say 10, 15 years ago, that demonstrated that cognitive behavioral therapy in children at the age of 7 to 10 could really transform their trajectory over decades. The challenge that we have is that the need for mental health care is far greater than the available resources we have. We simply don't have enough clinicians available. We don't even have enough mental health professionals to prescribe medications for the extent of the need. And access to care is quite limited. And so what we really need to do, instead of talking about removing a tool from our toolkit, is really focus on ways to get folks to the care they need at the time that they need it. And earlier is always better, because I think it can be transformative for a child and through adolescence if they have the care and the support they need. It certainly could change their life. And that's remarkable.
We've got a call now from Beatrice in Euclid. Beatrice, welcome to the Sound of Ideas. Please go ahead.
Hi, thank you for taking my call. I'm aware that, generally speaking, most psychiatrists do not run a basic profile, a nutrient test, blood test to check for deficiencies, especially in B vitamins and essential minerals. And I'm also aware in other countries, especially Germany, that virtually nobody is put on a psychiatric drug before first they place them on a comprehensive, fully methylated B vitamin supplement to see. And 80% of the time, this works. Why isn't this done in this country? Thank you.
Thank you for the question, Beatrice. Felipe, I'll ask you about this. Do you have any insight into potentially blood testing and testing levels of B vitamin before medication is prescribed for depression?
So practices vary considerably from one institution to another. In our department, we do part of the workup, and it involves, and a little bit of the discretion of the physician, a panel of different blood work markers. Vitamin D as well as vitamin B are usually looked at because of their connection to mood disorders. And yes, we do also consider nutrition and other aspects of the person's life as a holistic approach to care. So, and indeed, there's a lot of variance in how we approach these disorders from continent to continent, whether it's Europe or Asia or South America. But the information available regarding the effect of dietary practices and changes is not nearly as robust as the information available of the combination of SSRIs plus cognitive behavioral therapy in redirecting a condition that it tends to be chronic and disabling. And to piggyback of the comments made earlier, there's mounting imaging evidence that cognitive behavior therapy actually changes brain structures in a way that is enduring. So the treatments do change the trajectory of these conditions, particularly when they're available early. Unfortunately, accessing care for kids with severe mental disorders is very difficult, particularly if the family has limited resources.
Corinne, do you have any thoughts you'd like to share on anything that Beatrice raised there?
Yeah, I mean, I think her point is an interesting one, and I would argue that most of the time, SSRIs, for example, in this country are prescribed by general practitioners or family doctors who do often, do consider blood work as part of that, and usually it's an iterative discussion process that gets the patient to the point at which those medications are prescribed. But certainly we have to look at the whole picture. I actually think there's not a mental health professional, no matter what the degree is after their name, whether they're a social worker or a mental health counselor or a nurse practitioner or a psychiatrist or psychologist, that isn't trained to take a kind of careful and considerate, thoughtful approach to determining a treatment plan, which certainly should include, and I would say probably likely includes most of the time, consideration of physical health factors and blood work and all kinds of things.
Jonathan, I want to ask you as we start to wrap things up here, we'd be remiss if we didn't bring up the conversation about the relationship between the pharmaceutical industry and also healthcare providers. Do you think that's something that we should be taking into consideration as we're looking to what's appropriate in the mental health care industry?
Well, obviously, it's a subject that has some importance, and it has been documented that some of the pharmaceutical companies have engaged in bad behavior. Some studies have been suppressed in the past that did not show the results that the companies wanted. But we have lots of other evidence. The companies, I sometimes hear this by critics of the pharmaceutical industry and by critics of antidepressants in particular. I often hear this expressed as, well, they have a lot of money at stake. That's capitalism. That's how companies operate. They do want to make a lot of money. That doesn't mean every product they make is bad. It doesn't mean that their products are useless. I would give the example, the analogous example of vaccines. Pharmaceutical companies also make vaccines. They can make money from vaccines. That doesn't mean we shouldn't be using vaccines either. I think it's healthy to have some critical skepticism towards all our institutions. But I think I want to, if I may, shift a little bit to another subject that Dr. Kaufman and I were talking about.
I would love to shift to that subject. Unfortunately, that's all the time we have for the show. So we will certainly have to continue this conversation. Thank you so much, Dr. Jonathan Sadowski, Professor of History and Medicine at Case Western Reserve University, Dr. Karine Koifman, Professor of Psychological Sciences at Kent State University and Director of the Brain Health Research Institute, and Dr. Felipe Amunanetege, Child Adolescent Psychologist at University Hospitals. Thank you for the time today.
It was great to be here.
Thank you.
Appreciate it.
Yeah.
If you missed any part of today's show, you can hear a rebroadcast tonight at 9 on 89.7 WKSU, and every episode of The Sound of Ideas is wherever you get your podcasts and on YouTube. To get the last word on today's topics, you can email us at soi@ideastream.org and find us on Instagram at The Sound of Ideas. Yesterday, we aired a conversation with the author of Shade, The Promise of a Forgotten Natural Resource. In the book, they write about the dangers of heat and sun exposure and how crucial air conditioning can be in the summer. And Doug emailed in and said, I live on a heavily tree-lined street with 80-foot oaks. I haven't used my AC in years. Doug, that sounds really nice. Thank you for sharing that with us. Tomorrow on The Sound of Ideas, we'll talk about various nicotine products on the market and their risks to our health. And then we'll bring you the menu, all about food trucks in Northeast Ohio. I'm Stephanie Haney. Thanks for keeping the conversation going. We'll see you back here tomorrow on The Sound of Ideas.